Welcome to this episode of Evidence of Greatness. And for this time around, I'm going to be walking through an article that's entitled A Systematic Review and Meta-Analysis of Predictors of Response to Trauma-Focused Psychotherapy for Posttraumatic Stress Disorder. Now, this may seem like an unusual article for me to review, because obviously we're not, from a solution-focused perspective, we're not a trauma-focused psychotherapy. But I think that there are some really important implications of this study for solution-focused practitioners. And so I really wanted to spend some time looking at this. In addition, this is a really recent article. This was published in this year, 2024. And so this is, as far as we have, some of the most up-to-date research on helping people manage post-traumatic stress disorder. And so I just want to be really upfront in this. And I'm just going to say this study, I think, points to a lot of the reasons why we do what we do in solution-focused brief therapy. You'll see as we go through, and I'm just going to say, I understand that I'm a biased reviewer of this article. And so I just want to acknowledge, like, my agenda is to demonstrate why solution-focused brief therapy might be a good alternative when working with people who are experiencing trauma and PTSD. And so please know that that's going to be my agenda as I walk through this article. But I don't think that the conclusions that I'm going to draw are going to be very far-fetched. And so we're just going to walk through this, and you can just know what my background is as we go. So the authors begin the study with a literature review, and they talk about how PTSD affects up to 5% of the general population, although the statistic that they cited came from an article that was written in 2014, so it could have gone up in the last decade. But they also then talk about how trauma-focused treatment is the frontline treatment for PTSD, and it's most treatment guidelines recommend a trauma-focused psychotherapy over other types of therapy and over pharmacotherapy, which is medication. So with that in mind, it's really important to realize this kind of therapy, trauma-focused therapy, is being recommended the most of any kind of therapy when somebody comes in with a trauma. And the reason why I'm highlighting this is because as solution-focused therapists, a lot of times people will ask us, well, does solution-focused brief therapy even work with trauma? Can you even do it with people who are experiencing trauma? And part of the reason that they're asking that is because trauma-focused CBT or EMDR or those kinds of things are being recommended. But there are some significant implications of that. So they also clarified in the literature review that trauma-focused treatments refer to a range of treatments. It's not just one particular treatment, but there are some commonalities that make them trauma-focused. One is that the client is required to revisit the memory of the trauma. Two, they're asked to process the associated emotions. So when you revisit those memories, what are the emotions that come up for you? And then three, typically they try to alter the negative thoughts about trauma or about themselves, the negative thoughts about themselves, with cognitive restructuring. So these are the things that all of these trauma-focused treatments have in common. Now, I think one of the things that's really important right here off the bat is even in the literature review, they say between 1/3 and 1/2 of clients do not optimally respond to these treatments. And they can continue to display persistent PTSD symptoms. So this is the most common form of treatment that's being recommended. And at least 1/3, but potentially up to 1/2 of clients don't even improve. They don't respond optimally to these treatments. And that's a really nice way of saying they don't get better, but it doesn't necessarily include the consideration of, do they get worse? And so I think that's something really, really valuable to think about as far as solution-focused brief therapy is concerned, is that we don't ask people to revisit their traumas. We don't ask them to talk about or process the negative emotions that come up as a result of that. We don't try to alter their negative thought patterns. So we don't do any of these things, which might mean, could we be implementing more useful treatments for this 1/3 to 1/2 of people who don't respond to trauma-focused care? So at the very least, there's 1/3 of people that we might be able to access, up to 1/2, but that's not even considering, could solution-focused brief therapy have better outcomes than these approaches? Meaning, could more than 1/2 of people optimally respond? So I think that's something really important to consider. Continuing on with the literature review, they say to address the gap in the treatment, so for this 1/3 to 1/2 of people who don't respond well, most of the time they go on to augment trauma-focused approaches with what they call fear conditioning models. And this, in essence, is what they either call extinction learning or exposure therapy. So this is where you expose the clients to the stimulus of the PTSD flashbacks in a safe environment until they feel like those stimuli aren't threatening to them anymore. And so I think that's one of the things that's really important, is that they, in essence, crank up the thing. They say, in essence, we're just going to expose you to the fear in this safe environment. So instead of doing something different, it's almost like they engage in, let's expose you to the fear. Let's ask you, instead of just to remember the fear, actually experience the fear. One of the things that they mention is that the amygdala is associated with the fear response, and the hippocampus registers context or surroundings in the memories. So the fear, in essence, the hypothesis is fear becomes overgeneralized in people with PTSD because the amygdala is flooding the hippocampus, and the hippocampus isn't registering, oh, this is a different context. So the idea is, if we flood you with that fear, but you recognize over time this is a safe environment, you're going to stop overgeneralizing. So this is called exposure therapy. So again, one of the things that they do is kind of ratchet up the experience or the exposure to the fear-inducing stimulus. So if trauma-focused approaches don't work in and of themselves, then they go to these fear conditioning models. In addition, pharmaceuticals, they mention target neurotransmitters within the hippocampus and the amygdala. And so they've tried to mix these pharmacy approaches with this kind of fear experience. And the result of that, mixing drugs with this exposure therapy, has resulted in mixed results. There have been mixed results, and the effectiveness of this approach just barely goes to the exposure therapy results. They also talked about how there's transcranial current, which is electroshock, or transcranial magnetic therapy, and both of those have been shown to be ineffective. So the conclusion that they draw at the end of the literature review is that there's no treatment that has been shown to be particularly strong when working with people who are dealing with PTSD and trauma. So again, I want to be really clear, that is not my conclusion. That is the conclusion that these authors came to at the end of the literature review. They then go on from this place of saying there's no treatment that's been shown to be particularly strong, and they then look at all of the literature that they can find that says, what do the studies say about what's working? So they go into this idea and they say there's effective factors. They say eliminating co-occurring disorders such as substance abuse, depression, suicidality, or physical conditions helps. Overcoming compromised executive functioning, which is here in the frontal lobe. Eliminating persistent negative thinking. Developing an internal locus of control. Managing shame and guilt. And one of the reasons why they say that this is important is because exposure therapy doesn't address shame or guilt. It really is only targeting the fear response. And so they mentioned that this one might be one of the reasons why exposure therapy or these trauma-focused approaches might not work so well, is because it doesn't really address shame or guilt. They also mentioned that positive social support helps. And typically, males and younger individuals and higher SES eliminate other stressors, and therefore they tend to have more positive outcomes. Now, I'll come back to a lot of this at the end, but this is kind of where they began. So then they get into the methods, and they looked at 3 different databases. Actually, no, 4 different databases: PubMed, APA PsycInfo, PTSD Publications, and Cochrane Library. They pulled all of these things. They used a whole bunch of search terms, which I'm not really going to get into, but in essence, all of these searches resulted in 21,663 studies. In addition to that, they then hand searched anything that they could find that was on the topic of PTSD, and they found an additional 950 articles. So with the original 21,663, they went through and they looked at them and they said, let's eliminate anything that's duplicated. They might have gotten multiple of the same article from these different search terms and different search engines and those kinds of things. So from 21,000, they ended up with 16,064. They then added in the 950 that they got from hand searching. And then they looked at the titles and the abstracts to see, are there further duplications? Which obviously, if you were looking, that then resulted in a total number of articles that they looked at as 17,014. So then after that, then they looked at the full article and they said, is this really pertaining to what we're looking for? And they eliminated a lot of articles at this point. So they got it down to 2,383. So that's where they looked then at the potential eligibility for full text articles. So they said, based on exclusion criteria and inclusion criteria, they were only looking for adults. They were only looking for people who were experiencing PTSD. They had to have had a diagnosis from a DSM, all of those kinds of things. That then resulted in 161 articles that were considered in this meta-analysis and the systemic review. So 123 of the articles they included in the systematic review, which is a qualitative analysis, and 114 of them they included in the meta-analysis. Now, obviously, some of those are duplicated across. So we're looking at qualitative or process outcomes versus quantitative outcomes. So from there, they said there were 57 randomized controlled trials, and there were 57 non-randomized controlled trials. That's how you get to the 114 studies. This resulted in a total of 61,970 participants, so a huge number of participants across multiple studies. The mean age was 40.14. About 40% of the sample was female. 46% of the population were civilians. 46% were military or veterans, and 7% were refugee or torture survivors. So that speaks to a little bit about the different types of trauma that these individuals might have experienced. And then they reported what are the statistics about the different types of trauma. 40% from combat and war, 7% from acts of terror or mass violence, 17% of interpersonal violence, 3% from accidents, natural disasters, or medical illnesses, and 33% of people had kind of a mix of those things. So that's the sample. That's the people that they included. 61,000 people, almost 62,000 people. That's a really big sample. And so we can look at what they found. They also then kind of broke the sample down into when did they experience trauma. 68% of the sample had adulthood trauma, 4% had childhood trauma, and about 18.5% had some of each childhood and adulthood trauma. And then they looked at the number of sessions that were provided, and most of the studies, 66% of the studies, fell between 7 and 11 sessions. They didn't really comment on where the other 33% of this 34% of the studies fell, but I'm guessing that some were shorter than that, some were potentially longer than that. But predominantly, they're looking at about 7 to 11 sessions. So then they broke down the results. So this is where they say what happened when they gave these trauma-focused approaches to these people. What happened? And they looked at the fear biology factors. This is, again, the amygdala, where the emotion part of the brain is, the hippocampus, which gives you kind of memory, also context, place, orientation, time, present, future, past, and then also some of the frontal lobe. So this is kind of the fear system of the brain. And 6 studies looked at this, and they said, in essence, if you can activate this, system to respond, people tend to have better outcomes when they're dealing with PTSD. So I'm going to slow this down and say, so what does that mean for solution-focused brief therapy? Think about it. The amygdala is the emotion part of the brain. And one of the things that we found over and over and over in solution-focused literature is that when people experience solution-focused conversations, they experience positive emotion. So this would be an immediate counter to this fear response. So if I can help people to feel positive emotion, and then the hippocampus kind of keeping orientation of past, present, future, if I'm describing the history of the outcome, it's clear that it's in the past. If I'm describing a desired outcome or a preferred future, that is the future of the outcome. So I'm helping people to articulate and distinguish when I feel positive emotion, when my desired outcome is present, what's different. And I'm breaking down this fear cycle. In addition to that, I'm asking people to use logic and reason to hypothesize or create meaning from experiences either that they have had or that they might have. So solution-focused brief therapy is really addressing all 3 of these regions of the fear biology factor, which then the finding says if I can activate that system, they're going to have better outcomes when they're talking about PTSD. So immediately, we find solution-focused therapy might be a really good alternative because it's going to activate this neural network. We're going to do it in a positive way. We're going to do it with an orientation to time. We're going to do this through asking them to articulate things they've never articulated before and use that prefrontal logic region of the brain. So I think there's some huge implications for solution-focused brief therapy here. The second part here, they said psychological reactivity. People who are psychologically aroused and had a response to fear provocation prior to the therapy. 7 studies looked at this, and they said people with higher physiological reactivity at baseline were associated with better PTSD outcomes. So one of the things that they measure is like heart rate and blood pressure and those kinds of things. And they say if it's elevated, they're more likely to have better outcomes. And I think one of the things that this can correlate to, obviously, within trauma-focused research, is they say if we make them afraid, all of that will escalate. They'll be more engaged. They'll be more intent on making it stop. But they don't talk about how there could also be a positive arousal in that way. I could help people to feel excitement, joy, and their heart rate would increase, their adrenaline would increase. And so I think, again, solution-focused brief therapy has a really good use for increasing this physiological arousal, which could help people manage and deal with PTSD better. And then there's this third component, which is all about genetics, which obviously you can't do much with as far as solution-focused brief therapy. But it basically said that if they have these factors, it's usually associated with poor outcomes. So we can't really know that when we're working with our clients. And so therefore, I'm going to say we can't, that's outside of the range of what we can attend to as solution-focused brief therapists. They then get to executive functioning, and 5 studies looked at executive functioning, and they said increased executive functioning, including attentional control, predicted better outcomes. So if I can attend to trying to control this response, if I can use my logic, my reason, if I can get into my own physiological responses, then I'm going to have better outcomes. And again, think about what solution-focused brief therapy asks people to do. Consider what would be different when things are better. Pay really close attentional detail. What would you hear? What would you see? What would you experience? What would you feel? Who would respond to you? How would you respond to them? There's this really acute attention, which increases executive functioning, which therefore increases PTSD outcomes. So again, solution-focused brief therapy is really well situated here. Trauma-related cognition, they said 13 studies looked at trauma-related cognitive distortions prior to treatment, and people who had cognitive distortions were more likely to have poor outcomes. Now, again, basically what that's saying is people who are attributing things about themselves or about the situation as problematic, they're going to have poor outcomes. Think about what solution-focused brief therapy does. It, in essence, says, tell me about the very best version of you. They start to make these positive attributions. They start to get rid of automatically cognitive distortions because they start to tell me the best about themselves, which increases the possibility of positive outcomes. They mentioned that they looked at anger. 7 studies looked at anger, and they said people who are angry are associated with worse outcomes. Again, we do an approach that improves positive emotion. So the things that are getting in the way of positive outcomes, such as anger or emotional regulation or trauma cognitive distortions, we deliberately do something different than engage in those or make them worse or trigger them or expose them to them. And instead, we do something to invite the opposite of all of those things. And so all of these factors that they're saying, this would get in the way and that would get in the way, and this explains why we're not having the outcomes that we want. Solution-focused brief therapy does something different than all of those. And then the last bullet point here is that social support. There were 16 studies that looked at social support, and they said higher levels of social support that's positive predicts better outcomes. Again, think about the descriptions that we do. Who would be the first person to notice when things are better? Who would be most pleased to see that? What would they notice about you? And we do all this rich description about positive social support. So we're directly doing things that will improve the likelihood that they can manage this PTSD well. They also then looked at trauma-related cognitions. They said service-related disabilities, so oftentimes veterans, have poorer outcomes. If they have pain, they usually have worse outcomes. If they're not sleeping well, they usually have poor outcomes. And if they have a poor quality of life, they tend to have poor outcomes. So this is in essence saying who's walking in the room. Now think about this. We have studies that say that, that solution-focused brief therapy works with all kinds of medical conditions, helps people not only to feel better physically, but also feel better psychologically. We have studies that say that it helps improve sleep. Most of the studies that we have say it improves quality of life. So all of these things that are saying it either gets in the way or it improves the outcomes of treatment, there are studies that back up that solution-focused brief therapy can help with all of these issues. So it removes all of these trauma-related cognitions that get in the way of successful outcomes. And then the last part down there talks about demographics. 7 studies looked at the demographics, and they said males tend to fare worse. In addition, I'll go on, and it says education didn't have a predictive outcome. 6 studies looked at this and said Caucasians or Europeans had better outcomes. And 5 studies looked at age, and they said if the older you are, the worse outcomes you tend to have. Now, again, I'm going to say, and this might sound really cavalier, but I'm going to say ignore all of this, because this is now trying to generalize who gets better and who doesn't. But there's so many conflicting variables here. Men tend to go to combat more than women. We know combat is a factor that decreases outcomes. We know that men tend to be and hold anger in visible ways more than women do, which again produces negative outcomes. When we look at race, there are 114 studies being considered in all, and only 6 of them looked at race. That means there are about 108 that didn't even consider race as an option. So that's one of the things that I really want to highlight here, is that if we get pigeonholed into who can get better, men, white men, who are young, in essence, what we have concluded is if you fit into a privileged category, you are more likely to improve. And that's a problem. That's a generalization that I think solution-focused brief therapy can overcome by saying, we're going to customize this approach to each person that walks in. When you look at the trauma characteristics and severity, they talk about how trauma onset Childhood trauma is associated with poor outcomes. The more trauma I have, the worse outcomes I have. The longer it's been that I've been dealing with this trauma, the worse outcomes I have. Now, again, I'm going to say be very, very careful with that knowledge, because in essence, what it's saying is there are compounding factors that make getting better more difficult. But that's a power and a privileged position to hold. And I would say solution-focused brief therapy has been shown to be useful with people managing trauma. And we want to hold on to that and say, let's customize this for what would help this individual get better. These are just a continuation, actually, of the last slide. Service-related and combat, worse outcomes, pre-treatment, pre-severity, poorer outcomes. All of these things go along with exactly what I just said. Ignore these things. We do not want to have somebody walk in and say, oh, you are doomed from the outset. All of these things were presupposed at the beginning, which inevitably increases the likelihood that I'm going to do something in therapy to say, you must have significant cognitive distortions. You must be experiencing negative emotion, which it may not be true, but also the treatment that these people were asked to endure simply exacerbates each of those things. It says, relive this trauma. Walk me through really closely how severe it was. Walk me through how difficult and painful it is. Walk me through all of the attributions you've made about yourself. So one of the things that I would say about this is that these factors cannot be relevant in a solution-focused therapy session because we don't make them worse. So the final thing that I'm going to talk about as far as results go is these psychiatric comorbidities. They mentioned depression. Worse, if you have comorbid depression, comorbid alcohol use, or comorbid personality disorders, you also tend to have worse outcomes. Now, again, you can take everything I said about the previous slides and apply it to this slide. But I want to get to this in the discussion. And they said these, again, are their points from the discussion. They said special attention needs to be given to improving the treatment response in complex cases. So these are people with depression. These are people with alcohol misuse. These are people with personality disorders. And they say better treatment needs to be given. In addition, they said more attention needs to be given to how to modify maladaptive thinking and that it could enhance treatment responses. So if we think about better ways to change their thinking, the response to the treatment will get better. Well, what a better way to change their thinking than by helping them to focus on their desired outcome and to say, what kind of person, who would you be when you are thinking that way? Then this list, I think, is really important. These are other things that could enhance treatment. Focusing on improving emotion. So they said if we can improve emotion, people will get better, which is the opposite of inducing fear, which is the opposite of flooding them with the thing that's making them afraid. We do that by saying, what would you most like to be experiencing? Removing ruminations and negative thought patterns. What a better way to remove negative emotions and thought patterns than by asking them to think about something entirely different? Decreasing dysphoria, right? Think about it. People walk out of SFBT feeling better. That automatically decreases dysphoria. They say improving executive functioning. Walking through these really detailed questions that increases executive functioning. Improving pro-social interactions. If I'm asking you when you're at your best and when you interact with people who recognize you at your best, what does that do? It increases pro-social interactions. They also mention when you address shame and guilt. Now, I'm going to say we do address shame and guilt by replacing it with what they would rather be feeling. And when they start to notice that they're feeling those things, shame and guilt automatically decline. And then they also mentioned letting people choose their own form of treatment. We start from the very beginning to the very end by saying, in essence, we're going to honor your agency and autonomy. So all of these recommendations about what would make treatment better, we can directly find links to those things in solution-focused brief therapy. So when someone says to you, can solution-focused brief therapy really be effective with people who are experiencing trauma? I want you to remember this list because it improves their emotion. It decreases negative thought patterns. It increases euphoria. It increases the effectiveness of cognitive functioning. It increases pro-social interactions. It addresses shame and guilt by saying, what would you rather have? And it honors autonomy. All of the things that they say could make treatment better, we're doing. So I think that's really, really important. Now, here's the final reference for your consideration. Now, I know that was a really biased consideration. I know that I came from a place of solution-focused brief therapy could be really useful here. And that's not what this article was suggesting. This is not what the article was reporting on. But I want to say they did say there are some real limitations to the way that we're providing treatment for this population. And they gave significant implications as far as treatment, things that we could do better to improve the outcomes. And solution-focused brief therapy meets those recommendations time and time and time again. So when people say, can solution-focused brief therapy help people address trauma? I would say, yes, hands down, but potentially even better than trauma-focused approaches. So take that for what you will. Please let me know in the comments what your thoughts are about this. Please feel free to share this video with other people who need to hear this content and to consider a different option than trauma-focused approaches. I hope that's helpful for you. I'd love to hear your feedback.